Top Med Talk.
Well, hello and welcome to Top Med Talk, coming to you live from the World Congress of Prehabilitation and Perioperative Medicine, being held in conjunction with the annual ERAS Plus conference here in Melbourne, Australia. I'm Kate Leslie and I'm here with my co-host, Mike Grocott. Mike, are you enjoying the conference?
I am loving the conference. Lots of great science. Lovely to see everybody together again.
So you can hear that bell there. They're just going in from a lovely afternoon tea, lots of networking in the healthcare history. You have a rigorous schedule, 8 till 6 at this meeting.
Rigorous schedule, and there is a little bit of fruit out there, but you have to laugh at the fact that we're all about fine nutrition and there's great cakes that everybody's tucking into.
Exactly. So we're very lucky to have a great guest, Professor Shelley Dolan, who's the Chief Executive Officer of the Royal Melbourne Hospital. Shelley, can you tell us a bit about how you got to Australia and the Royal Melbourne and what you're doing at the conference?
Yes, of course. Thank you. And thank you both for inviting me on the podcast. So I started life as a critical care nurse in England, then was really lucky to work in many brilliant centres over the UK, Europe and North America. And then I, at some stage in my career, went across to the dark side to management. Became a chief nurse, a deputy chief exec, and then a chief exec. This is my third or fourth role as a chief exec at the Royal Melbourne. I came to Australia 5 years ago for a job at Peter MacCallum Cancer Centre. Then after 4 years, which I absolutely loved at Peter Mac, and where the first time I met Bernard and all of the prehab work that is done at Peter Mac, then I just walked over the precinct to the Royal Melbourne and absolutely loving being the chief exec there. Why did I come to the conference? Because I really, really believe in prehabilitation and ERAS Plus. I was very lucky to be part of a fantastic critical care team in Oxford and then later at Guy's and St Thomas's and then at the Royal Marsden, looking at how we could improve patients' well-being and physiological parameters so that they avoided having to be admitted to crit care. And that work started in about 1999. And out of some of that work came some of the ERAS work that I was involved in the UK, I guess in the early 2000s. I saw as a nurse working with dietitians and physios and anaesthetists, intensivist surgeons, that we could really improve both the outcomes of some of our patients' care, but also their experience of care. And I think the thing I really liked, we did a project that we published in patients undergoing esophagogastric surgery for cancer. And with much better preparation, we saw some people decide not to have surgery because they were better informed and understood that it wasn't just a big surgery and that was it. You were better immediately, that there is a lot more to complex major surgery. So I really believe in it and I try and always support this conference.
The thing that really interests me, particularly, Shelley, with your experience of having worked in multiple systems and the NHS and then obviously in Australia it's a lot more private, is how we set the system up so that the incentives drive good behaviour. Because
yes,
it often feels like it isn't that way.
Yeah, I agree. I guess for me, somebody said it earlier, this shouldn't be about a project. This is about incentivising teamwork with the patient and the family and the whole multidisciplinary team. And that really should be standard of care. It's the right thing to do. Where you have activity funding, which a lot of the world still has for healthcare, not all, but quite a lot, the payment for ERAS is bundled up into your payment for every patient.
A couple of sentences on what is activity funding?
Yeah. So you are paid for the amount of activity. In Australia, we are paid in units called NWALs, which is your National Weighted Activity Unit. And each unit has gone up and it's now worth about $6,300. The kind of activity you do, whether it's cardiothoracic surgery or neuro or outpatients, has a national average score. The Royal Melbourne is a big place, so it has a lot of activity, but you are capped at 100% of achieving, if you're given, 100 NWAL, which would not be enough, but if you achieve 100, then that's where your activity is capped.
But you bid for them, don't you?
No, you are given them by government, and then you have a discussion about whether that's enough.
Yeah.
And that's based usually on your previous year and what you achieved. Now, currently across the world, because we all know that the pandemic slowed down planned surgery, and I think most of us are still making up that diminution in the number of people operated on. I think we're all trying to get wait lists down and get planned surgery up. So we're trying to achieve above the target NWEL, so above activity. And for that, you need to agree that you will be paid for that above. And the other thing to say is that when it's activity funding, it's based on this patient having an esophagogastrectomy costing this much, but you never get 100%. So you never get what it actually costs. You get probably, in most systems, UK and Australia, about 75% of that. And you have to make the rest up by non-governmental financial resources or productivity.
Productivity means working harder and doing more patients in a shorter amount of time.
Yeah, I mean, look, I think productivity sometimes gets a bad name. I don't think it's about working people so hard that they don't enjoy their roles anymore. And actually, we know that you're no good at your role if you do that. But it is about, if I give surgical examples, everybody getting to theatre on time. It is about being really productive about the way we see patients in outpatients and doing virtual clinics. And so just doing our work more efficiently and better for patients, but not flogging the workforce.
So the activity funding, if I understand you correctly, there's a good incentive there in that it encourages you to look after patients well so they stay less long in hospital, for example.
Correct.
So you minimise your costs and you maintain your income.
Yes.
But it still encourages you to do more, rather like the fee-for-service approach in the US.
Completely.
I mean, how would you, as a chief executive, feel if instead they said, look after this bunch of people and here's some money. You decide how you spend it, from vaccinations to the whole sort of capitation model.
I've worked in that model. I think the models in southern Germany and in Denmark are really good. The thing with capitation models is they're not just hospital. They are the whole system model. And where it works best, like Manchester devolution, is where you put youth justice in there, where you put schooling in there, where you put housing in there, population health, so that you address the social determinants of healthcare. You cannot do that if you're looking at what your surgical budget is. When you get really good data, as they did in southern Germany, must be 20 years ago now, from actuarial data, and looked at what the population actually costs, and then put everything in together. And then you're not just meeting with other hospitals, you're meeting with primary care, community care, but also schools, healthcare, refugee associations, etc. That is where you get it right, I think. But it is a bold health system that does that, because it takes years to. So if you look at the data now, southern Germany and in Denmark and Sweden, yeah, it's worked, but it doesn't work in a 3-year political cycle. So you have to be very brave to do that.
So I'm in academic management leadership, and there's resource constraints and all the rest of it. But I always feel it's a relatively comfortable place compared with the sort of operational, particularly NHS type leadership, where the buck stops with you, and there's always problems in the hospital.
Yeah.
How do you stay sane?
I think the most important thing is the people, having a brilliant team. So at the Royal Melbourne, we have a fantastic executive team, and we're all absolutely focused on doing the best for patients, families, our community, and the staff that we work with every day. And so if you're working with brilliant people, it just makes everything easier, because it is all a team game, isn't it? And then I just met one of our cardiothoracic physios that I've never met before, and she's asked me to go down and visit them and see what they're doing. And it's stuff like that that really balances everything else. I also think, I know this sounds a bit out there, but I do think we're very lucky to work in healthcare, because it's a real purpose-led environment. And I have lots of girlfriends who work in industry or legal or something else. They sort of envy us because we're really passionate about what we do, because we can make things better. So actually, I think it's fab to do what we do, really.
I completely agree with you. I think it's a really important message. It's surprising how often people lose track of that.
Yeah.
They're so sort of drawn into the day-to-day problems,
Yeah.
they forget how lucky we are.
Yeah. I always think if I'm having a day where, I don't know, difficult decisions about budgets or things like that, I think I'm going to go and visit a ward. And do you know what? Just walking around a ward, sitting down, chatting to patients and their families, it just immediately makes you think, what am I worried about? There's this person who's going through all of this. And it reminds you again why you do what you do. So I think we're enormously lucky.
So we've talked, clinicians trying to work with hospital executives and those things about the budget. But as an executive, you're on governmental committees and other committees. How do you get your passion for quality and safety to actually get the politicians to drink the Kool-Aid that everyone at this conference is clearly on?
Yeah. So look, I've worked with politicians of probably all flavours across several countries. And I think most of them do what they do because they want to make a difference and they want to help their community. And so I think it's about 2 or 3 key things. First of all, I always make sure I'm really well prepared, even if it means I'm reading something at midnight and then distilling it into bite-sized chunks so that I can be really articulate, really concise and precise about what my messages are. And then I try and always do it in a way that's kind and collaborative so that I'm helping them to help me. Because we're all human beings and we all get wound up if people start attacking us or whatever. So if I can help them to understand that ERAS Plus is worth taking attention of and understanding, and as somebody said earlier, it's not actually a very difficult concept to understand. So actually doing that, and then I always get either I or somebody to prepare a one sheet that I can give to a politician or give to their aide so that they just got that afterwards to refer to.
And do you do the old don't give me questions, give me answers approach? Do you always go in with, well, if you want my opinion, this is what you should do?
Yeah.
It'd be a brave thing to do.
I mean, obviously, there are some times when you are pushed to that, but I think you develop relationships, and what you want to be is the person that they always come to. So when I was first in Melbourne, no politicians knew me, the Premier didn't know me, etc. And so my job was to kind of get to know them as a person that they could trust, that I wasn't going to spill confidences, I wasn't going to go to the newspaper, in the 5 seconds, and that they could come to Peter Mac or the Royal Melbourne, be treated well and learn about what we thought was really important. And then they come back or they ring you in the evening and say, could you help us with this or whatever. So I think it's like all human behaviour. You treat each other well, be prepared to be really clear and quick with your answers, and then always follow it up. I always, email the next day and say, thank you, that was great. I noted we discussed these things and that you promised me millions of dollars. Thank you.
Very good advice.
Well, there's so many things. We don't often get an opportunity to talk to a health system leaders who's hands-on with the levers of power. So I'm not going to stick with the health economic thing. Geeky.
I was enjoying it so much.
I'm sure. Speculative. I mean, everybody's obsessed by AI at the moment. It's going to replace people. And what do you think the place is? AI.
Yeah. So look, I'm really excited about it. We're part of the University of Melbourne, and then there's another brilliant university in Melbourne called Monash. And we did a joint symposium with them on AI. And 2 professors came from Monash around imaging and pathology. The Chinese professor, whose name I'm afraid I can't remember, was showing us MRIs and PET scans of really early lung cancer, and the AI algorithm being able to see tiny, tiny micrometastases, possibly before the human eye can. And then in pathology, they were looking at spatiomics. Now, I'm going to show my ignorance very quickly if I carry on, but But
What's basiomics?
well, I think, Kate, it is where if you've got a piece of tumour or something on a slide, piece of tissue on a glass slide, you tend to look at the messages it gives through your microscope, but is looking at the space it inhabits and how cells cluster on that margin or whatever. So it's literally 3D. I mean, somebody could explain it much better than me, but
Shelley's doing very informative hand motions.
Don't put that in real life.
In any way, there was a great discussion about PET scans and lungs cancer.
That's right. And the key was, so there were two things really. When does micrometastases get big enough to be useful clinically? In other words, do we all have stuff in our bodies that an AI algorithm can find, but actually is not really clinically useful? And if you told patients about it, they'd be worrying for a long time before it became manifest. And then the other thing is, when do we trust AI, or when do we say a doctor must always interpret the AI evidence? And then in pathology, as I say, looking at very big samples with the mass spec and proteomics and other omics, they were looking at druggable targets. And the beauty of using these various AI packages was that you could look at thousands of molecular targets, well, probably tens or hundreds. So it was quicker and you could get your targets much quicker. I'm not quite so worried about, I know there's been a lot of worry about security and all sorts of other things. I think we're a long way from that. I think there's some really interesting questions about how brave are we prepared to be about algorithms and the learning algorithms and generative AI. There's also in hospitals and healthcare a lot of non-clinical stuff that can be done by AI. I remember Imperial and UCLH, I think, maybe Barts, did some really good work around things like accounts payable and huge process stuff in hospitals with lots of people that can be done by a bot. I think it's a really exciting time.
One thing I'm worried about, though,
Yeah.
is what the humans are going to do. So about 80% of school leavers in the global north go to university or college.
Yes.
And they get either a vocational degree or a general degree that equips them to do all sorts of things. Not all of them can go into AI development. So what roles do you think human people will play in healthcare in the future? I mean, we even hear that robots are better at psychotherapy, for example, than human people.
Yeah, I was hearing that the other day. Look, it's funny, isn't it? Because we are all a product of our backgrounds and, you know, where we are in our life journeys. And I say, I've answered this question a few times recently, and I like to think that there will always be a place for that human interaction with each other and that caring and empathetic and compassionate interaction, teaching, all sorts of things. But then I might be a product of a generation that doesn't realise that robots will be able to do that at some time. You know, I don't know. Also, we will be able to afford robots. Will they be cheaper than humans? I don't know. I don't think we're anywhere near that yet. But I do think also on the diagnostic front and the monitoring, you know, diagnostic and monitoring of patients, AI must be helpful.
Well, there's a big thing that we talk about often on Top Med Talk, actually, is about hemodynamic monitoring on surgical floors. But the big piece that's missing is who is going to respond and what are they going to do?
Yeah.
We need a bunch of humans to do that, presumably, Mike.
I mean, at the moment, we need human effector mechanisms. I'd actually be quite worried if I was a surgeon, and I'm sure we're not supposed to mention brand names, but some of the robots record every single activity, so every procedure, every movement, all the sensors. So presumably they are learning in terms of the volume of input at a much faster rate than any individual human surgeon could, and will slowly start to be able to take over at least sort of micro routines like suturing and dividing tissue, that kind of thing. And I mean, I think it's fascinating. Most manual procedures, I think they could take over. It's just whether it's going to be cheaper or not. We've already had the discussion earlier. It's a robot.
The cost of robots and the consumables, which is incredibly expensive. We also don't have enough people in some areas. We don't have an even coverage of doctors or nurses across rural and remote Australia. And so we actually do have real problems with equity of access. I'm not suggesting at all that robots could do the remote and we would, have lots of people in metro. But if we could do some things in a bit of a dispersed fashion, we might have more equity of access.
We had a discussion on Top Med Talk once about operating on people in space.
Oh,
from Earth.
yes.
And the problem with that is the delay
Right.
is getting, 10 minutes later in Mars, you would
Yes.
find out that they're bleeding and you'd have to do a suture. So there's all sorts of improvements in other technologies that would need to come into play. So just finally, what else do you see in your future and in the future of ERAS in Victoria?
Well, so there's several people here today who have come up and just talked to me or others around how can they get access to ERAS in their hospital. We are now looking at a major reform in Victoria, of the health system in Victoria, which I'm very excited about. And that is all about improving care right across Victoria so that everybody in Victoria gets the great outcomes that people in the metro do. So I'm really keen, as soon as we get back to the farm, to work out how we're going to share some of the things that we learned today with the rest of Victoria and make it a reality. Because it's all of I think it was one of the Canadians from BC, they put up so many fantastic bits of information and resources that we can all use and share. So actually, it's not that difficult to set up an ERAS service if you've got loads of resources. The only other thing you have to have is really good teamwork and people that can work in a multidisciplinary way and respect each other.
It's been striking at this meeting, actually, compared with other ERAS and prehab meetings. There's been less of the trialists coming with here's my new data and more of the system changes coming along.
Implementation scientists.
We just got on and did it, and we spoke to our managers, and or the managers spoke to clinicians, and they did, as you say, work as a team and system-wide change in quite disparate places across the globe.
Yeah. And you see, it's very inspiring, isn't it? I was listening to somebody from Canada and thinking, gosh, they've got some really remote communities, as Australia has, and they've done so much in quite a modest and quiet way, but they've done amazing things. So I think there's a lot for us to do in Australia.
Thank you so much, Shelley. It was lovely to talk to you. Thank you for listening to Top Med Talk. You can find us on your favourite podcatcher or on the website, the Top Med Talk website. And you can also look at us on all of the socials, including YouTube. We'd like to thank our sponsors, without whom we couldn't be free and open access to the world. So thanks once again.
Thank you, Shelley.
Thank you.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.